I'm Dr. Michael Latola.
And I'm Megan Strong.
In this week's Case of the Week, a little CAD-CAM preview of the crowns would have gone a long way towards making this case go more smoothly.
And then we'll tell you about a study that reveals what we already knew, that your meat on the barbecue should be the only thing smoking.
Speaking of that, Megan throws a food throwdown challenge to the dentists of America, specifically Texas, and they respond. That and more on today's Chairside Live. Hey now, hello and welcome to episode 142 of Chairside Live. Megan, I would ask you how you're doing today, but I know you are really excited because of something you did 2 episodes ago. What did you do?
Yes, I said that I would like for somebody to send me some barbecue, and I questioned whether that would be even possible. And I'm here to tell you, dreams do come true. It is possible. You can send barbecue. Dr. Max Need from Fort Worth, Texas, so graciously, generously sent me some barbecue from a famous joint in Texas, and it was everything I hoped for and more.
Right, you took some pictures, right? We'll throw those up
yes.
now. What was your favorite?
Oh, the ribs.
The ribs.
So good. I'm a sucker for some baby back ribs, and they were so
There was
good.
a lot of them.
Yes.
It's what I would call not so sneaky meaties.
Right.
In your face meaties.
Nothing sneaky about them, but thank you again so much, Dr. Sneed. They were unbelievable. It was so good.
And you know what? He was not the only one who heard your siren call.
What?
For meat.
Say what?
There's another shipment that has come in.
Check the calendar. Is it December 25th?
It says perishable.
Oh, did you see the dry ice little smoke come
the
up?
dry ice. Yeah, that was kind of neat.
What do we
This
got?
is from Black's Barbecue in Lockhart, Texas. Ooh. I wonder if those 2 barbecue places, I hope we're not starting any kind of crazy rivalries here.
I'm nervous now. Let's see what we got.
It's just all dry ice.
Yeah.
Oh my God, now this looks like it's real honest to goodness, like put into, this is 2 pounds of brisket. Go ahead and hold on to that.
Okay.
Don't let the dry ice burn you.
Okay.
Some sausages.
Sausages.
Oh, there's original.
Oh my gosh.
There's garlic.
Even frozen, I can see like the crust sort of thing on here, and brisket has these things that are like burnt ends that are just, oh mama, I can smell it.
Jalapeno.
Jalapeno, also known as jalapeno. But
And spare ribs.
Oh my God.
See, this kind of looks like, look, it's like done with one of those things that you see on an infomercial. You know what I mean? It's like they actually put it in here and then just sealed it like that. This seems more, this seems less commercial and more kind of homey than the last one that
I'm very
you got.
excited
I think
about
so.
this.
It's going to be interesting
to
compare and
tell everybody
contrast.
who it's from.
It's from none other than Dr. Josh Austin, my co-host on the Accidental Geniuses podcast. And by the way, today we just released episode 7, which is episode 1 of the sleepover, our 2-part sleepover,
Scary.
where Josh and I both had to be in Chicago for dental stuff, and we decided
At least that's what you said anyways.
No, that's the reasons we were there, but we did decide to record a podcast from bed. Well, on the bed, but and so check it out. If you go to iTunes, check out accidentalgeniusespodcast.com. This is from Josh. Thank you, Joshy.
Thank you so much, Josh. I appreciate it. I can't wait to report back on how delicious it was. And listen, I'm just opening it up, okay?
Right.
We had Dr. Sneed, now we had Josh. If you have a local delicacy that you enjoy, it can be barbecue, it can be ice cream, it can be just about anything. Go ahead and send it my way.
I hope it's an Inuit dentist and you're got some blubber coming your way.
I'll take
the
anything.
on-screen challenge.
I will take anything.
You
at
eating
this
some
point.
blubber. This that needs to thaw a little, I'm guessing.
Yeah, and then you have to reheat it, and then it's just gonna get so good.
Wow.
Oh, gosh.
I wish we had the facilities here to do it. You get to do it at home, though, mainly because your name's on the box and not mine.
Don't try to touch it.
Right. So don't beg too much, but ice cream. Yeah, ice cream's going to be tough, but
No, if you can send legitimate, authentic Texas barbecue, you can send ice cream.
all right.
Do not doubt the people. I have faith in you. Every single last one of you.
If you guys send her something, put an extracted tooth or something in it. Not in it, but like in or around it. Just, I don't know, have some fun. Freak her out when she opens the box. Well, we got a great episode for you, barbecue notwithstanding. We've got a good case of the week. And it really kind of points out how with digital CAD CAM technology we can do things as a laboratory that we couldn't have done 10 years ago. And in this particular case that you're going to see, anytime you're making anterior restorations for a patient, you're not sure whether or not they're going to like how they turn out and you haven't done a diagnostic wax-up, you can always request to have us send you a screen grab of the designed crowns before they get milled so that you and the patient could look at them and decide if you like them before the crowns are actually milled, stained, and glazed and sent out to you and all that good stuff. So let's take a case where that would have been helpful. Last week, our case of the week was an anterior bruxer case where the material is so translucent that the underlying stump shade was showing through. And this week, we're going to look at a doctor who prescribed regular bruxer, and it was a good idea because the bite's very tight on the lingual, and it's the type of thing that might be too much for Emax crowns and other all-ceramic crowns, but it's a really good indication for bruxer. It's an interesting case. It's 8 and 9. And you can see that the teeth are obviously flared and there's some diastema that are present. And so we were not given any specific instructions on how to construct the crowns. And so crowns were made for 8 and 9. And what was done was the diastema was closed. And of course we have a little black triangle there because we don't have any gingiva. So the diastema was closed and they tried it in, and the doctor and the patient felt that the teeth were just way too big, too wide compared to, say, the lateral incisors. And just looking at them here, I mean, yeah, they seem a little bit wide, but it doesn't seem like it'd be a real deal breaker necessarily. But, that's why, there's a no-fault remake policy, so patient doesn't like them. They're going to get redone. And the doctor wrote back and said, please follow the shape and the size of the temporary crowns. He said, I know we're going to end up with some spaces, and that's fine, but the patient really didn't like the look of the big teeth. And so here is a photograph of the two temporaries in place. And that's still a pretty sizable diastema that's present there between 8 and 9, but those teeth appear to be about the right size. So if they're 10.5 millimeters long, the central incisors, they should be about 8 millimeters wide. And so that really looks like what the doctor's wanting to have done, or at least the patient wants to have done. And so what we're going to be able to do now, we don't typically do this on the first go if we don't get special instructions, but the technician is going to redesign these crowns to reflect that, to open up the diastema between these two crowns. And because you can see where it gets a little lumpy there on the mesial to kind of close that contact. So now knowing that we do want a midline diastema there, they're going to design these crowns and they're going to send a screenshot to the doctor to approve before it goes. And there's actually even been talk here in the laboratory of sending, giving the doctor design software so they can play around with the design if they want to as well. But I think most of the doctors who really enjoy that already have invested in like Chairside CAD CAM systems. So on a case like this, if you're ever wondering about anterior restorations, and if you have in mind what you think they should look like or you're not quite sure, you can always have us send you a screenshot of the proposed design for you to approve or make comments on before they actually get milled. So it's no big deal because now we're going to redesign these, send it to the doctor. He can even show it to the patient what the space is going to look like on the design file, and then we will mill 2 new bruxer crowns. But if you have concerns right off the bat, or you want to make sure that golden proportion is met, or you want to make sure that the lab sees the note about rounding off flatter cuspids because they don't want something that looks kind of fangy, you can always request that we send you a screenshot of anterior units like that before they're milled for you and the patient to approve and or make modifications to. Something else interesting on this case was when you look at the bite, or at least when you look at the original bite, there's hardly any room when the patient bites together. And so we had to actually do one of 2 things: call the doctor and say, what would you like to do? We can either spot the opposing, or have you reduce a little more on the lingual, or both, and it'll be a little conservative on both of them, so you don't have to take it all off of one arch. And the doctor opted to have us do a little reduction with like sandpaper discs down here on the lower anteriors, and also show him where to reduce more on the linguals of 8 and 9. And so even though it's sometimes tough to do, we actually made some axial wall reduction copings for the doctor and put those into place, this time on the right teeth. They look almost identical. So you can see they're little, as we zoom in here, you can see they're little thermoformed, I don't know, thimbles, I guess you would say. And basically it reflects exactly where we went in and reduced it. And so the one thing I would say about using these types of axial reduction copings, especially on a surface like this, it's a little easier sometimes on the occlusal surface, but for me it holds true the same, that usually, like if there was a cuss tip we wanted to reduce, like if this was a prep and we made one where this part of the tooth was sticking out through the reduction coping, that's easy. You can take any straight burr you want and just cut across until you're even with it. But these are a little different. These axial reduction copings, there's nothing sticking out of here to cut off. You actually have to get into that and do it. And that's the reason why I prefer a football burr. I want something that's convex so I can use it up against the reduction coping and actually get into the reduction coping and take some of that tooth away. In fact, I don't stop until the burr starts, just kind of destroying the reduction coping, because now I know I've gone deep enough where I'm hitting that reduction coping, and I don't mind. Now I'm in the right place too. And so if I have to go in and do some more, I can even do it with the coping off of there. But if you try to do this with a straight tapered burr like an 856, 016, or just a chamfer burr, it's hard to do. The round burr from the reverse preparation kit would probably work as well. You'd have to be a little judicious in its use to only kind of use half of it to go back and forth. But that might actually work. That would certainly be more effective than the football burr, but it would also possibly lead to over-reduction in that area. So the football burr is a little safer because it's still convex enough to cut through that opening into the tooth. But as you start to go deeper, both ends of the football, the tip and then down by the shank, start to hit the reduction coping, and you've kind of bottomed out when you've done that. So with the combination of those two, the reductions being done on the lingual with the copings, and then it'll probably be easier to see without these on, and then the sandpaper disc to the opposing. Now you can see now we have enough room. There's plenty of room there. That's almost enough room for Emax at this point. You'd like to have a full millimeter for Emax, and for solid zirconia, like regular Bruxer, like it's being used here, 0.6 millimeters will be fine. And so sometimes we do use these axial reduction copings, and if you get one from us, the easiest way to use it is to use a burr that's convex, like a football burr or a round burr, and it can be a very easy way to guarantee that you have reduced enough and duplicated what was done in the lab so that the crowns will drop right into place and be thick enough to withstand these anterior biting forces.
Thank you for that, Dr. D.
You're welcome.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Elliot Halpern, and he writes, Dear Dr. DeTola, I just watched your video about dark stump shades and translucent crowns, and it applies to a case that I'm currently working on. We are doing implant restorations on 7 through 9 and number 10 with the desired shade of A1. I prefer titanium abutments to zirconia abutments because of the better strength of titanium. Will a Bruxer interior crown work, or should I choose a less opaque alternative? Also, do you have data on the breakage of zirconia abutments? Thank you.
Well, Elliot, those are two really good questions. And with Bruxer anterior being a more aesthetic material than, say, traditional Bruxer, that does become a concern. And so one potential answer would be to use a zirconia abutment, as you pointed out. Now, you asked about the breakage rate, the fracture rate of those. Pretty much people are only doing zirconia abutments on the anterior teeth and the premolars. Nobody's really doing them on molars. In fact, we're really not doing all that many. If you look at all the custom abutments that we do, a full 95% are titanium, and about only 5% are actually zirconia. And so when you looked at the ones on premolars, I went and had to pull those numbers up today, surprisingly, I was surprised, pleasantly surprised, but the fracture rate on those is less than 2%. And as it turns out, just because of statistically how some things get measured, there's probably some cases in there where maybe an Emax crown that was on a zirconia abutment broke, and it gets counted the same way as a return and a remake as though the abutment broke. So the actual number might be, a couple tenths to 0.5%, actually lower than that. So anywhere from about 1.5% maybe to 2%, which was lower than I thought. But you're absolutely right. The titanium is clearly the stronger abutment, and as I mentioned before, 95% of the dentists are using that as their abutment material of choice. So the combination would have to be something along the lines of, if we were going to use titanium abutments, if we put Emax on that, it's going to show through. And as it turns out, if we put Bruxer anterior on that as well, it's also going to show through. And so that would take us back to our other choice of the traditional Bruxer or Bruxer Classic, whatever you want to call it, or just Bruxer. If we put that on top of a titanium abutment, it will not show through. So we're going to lose some of the translucency and therefore some of the aesthetics. The other option would be do a zirconia abutment, and then you're free to place, Bruxer anterior or an Emax crown on that, but now you're thinking a little more about, I hope this is going to be okay. So which one's the best choice? I mean, there's no right choice. It's up to every dentist to kind of say, am I leaning more towards aesthetics here? Or because it's a bridge, am I leaning more towards strength here, or a combination of those two? And there might be actually a third option. We've recently started doing a gold coat, as it's called, where we take a titanium abutment and actually put a gold coat on the outside of it. So it's not unlike, if you remember CapTech crowns, for example. They had a 22 karat gold substructure, and that kind of yellow feeling to the yellow gold looked a little bit like dentin. So when a crown's prep and the enamel's all gone, we have a darker stump shade than we do the final enamel shade. And so that darker yellow shade kind of gave it a warm feeling, and CapTech did have a reputation as being an aesthetic crown, maybe not the strongest PFM, but it did look aesthetic. And so this gold coat is applied to a titanium abutment and gives more of a warm feel to it, but it's still always a judgment call whether or not Bruxer anterior or Emax is going to let that show through. And there's no real definitive way to say it's always going to happen if this happens, it's never going to happen if this happens. So it might minimize that gray look, the way it'll gray out a crown when we have just a traditional titanium abutment. But it could help it as well. It's just always a little difficult to say. We do have a no-fault remake policy, so if you tried Bruxer anterior on a gold coat titanium abutment and it showed through or you didn't like it, it could certainly be returned. It could certainly end up that we do it and put it on there and it looks great to us, and we call you and say we should probably switch to something less translucent like regular Bruxer so that it doesn't show through there. So there's just a little bit of a choice to make there. And I guess if I was working on a woman from Newport Beach who, well, let's say I'm working on Megan, and it's a single tooth, and even though she's not from Newport Beach, but a single tooth implant right in the front on a young female without a lot of wear on her teeth, very concerned about aesthetics. I'm probably going to lean more to that zirconia abutment with the more translucent Bruxer anterior. Or an Emax crown on top of that. And if we're looking at somebody who's missing a tooth and we're doing 7 through 9 and maybe number 10 like you said, and it's somebody who's flattened their canines off maybe like me, then I'm going to be thinking about titanium abutments with probably regular Bruxer on it, especially if they show some wear on the teeth. So bottom line is, if you're doing that case on Megan, it's probably going to be zirconia abutment and a translucent crown. If you're doing it on me, you're probably going to go with a titanium abutment and something less translucent on top of it. And as it turns out, I hadn't looked at it in a while until you asked your question, but I was happy to see that the fracture on those zirconia abutments is less than 2%. Of course, if you're one of the 2%, that doesn't make you feel much better, but knowing that PFMs, tend to chip at a rate of about 5% over 5 years, or break or chip, whatever you want to call it, I feel pretty good about that, and I would be confident using it in a case where the patient had some high aesthetic demands, and I wasn't so much worried about breakage. I just wanted to make sure that aesthetically the patient would be pleased. So great question. Thank you very much. As a result of that great question, you do not have to send us any food items from your hometown.
Hey, what if he wants to?
Then I guess he can.
Thank you.
And maybe we'll trade him with some homemade ribs that Josh just sent to, homemade burrs.
Ooh.
Now, I stood over a hot mill and electroplater and made these burrs myself and put them into a reverse preparation kit.
Why don't I believe you?
Because I'm lying.
Perfect.
That's why.
How about this photograph?
Yeah, I like that one.
It's a good one.
There's
another one, but I'm pointing and it's awkward. I think this is a nice picture.
All right, we'll send it to Elliot with the burr kit. I'd like to be able to send out some pictures of you and meat.
That's odd. Well, I have pictures that
those are hands. Those are fingers. That could be anybody holding that
Okay,
meat.
so how about I'll pose with...
That's what I'm saying. Get the ribs, pose next to them.
Okay.
All right?
Got it.
Great. Any news?
Yes. A new study reveals that cigarette smoking attributes to almost half of the deaths caused by oral cancers. The study looked at adults 35 and older in the U.S. in 2011 and found that 48.5% of oral cancer deaths were from smoking. Researchers reported that smoking rates dropped more than 5% between 2000 and 2012, but the risk of cancer deaths among smokers increased over the same period. They noted that the study was limited. The population studied was less racially diverse and had more education than the general population. They also did not include secondhand smoke in their analysis. Exposure to secondhand smoke is estimated to cause an additional 5% of lung cancer deaths, according to the 2014 U.S. Surgeon General's report.
Yeah, I've seen research like this before, and it's even more damning when they look at two factors when they look at smoking and alcohol. And basically, if you wanted a recipe book for how to create oral cancer, it would be smoking and alcohol used in conjunction with each other.
Sure.
And not even necessarily chewing tobacco sitting in there, kind of smoking that you were talking about right there, that kind of tobacco. And it was one of the things that drove me crazy about the fact that Listerine was being sold. It was 27% alcohol. And every smoker now, they've been so marginalized, on the edges of society that they have to go hide in a stairwell. We have it here right outside right now, hiding in a stairwell, smoking for fear that people will identify them as a smoker. And then they run back in and they take this 27% alcohol Listerine and put it in their mouth and hold it and swish as long as they can, as the commercial used to say. How long can you hold it in? How many cell layers deep can you kill? And they'd spit it out, and it was just like, why? Why is there an ADA seal of approval on this stuff when you combine it with smoking? The people who are rinsing their mouth probably the most.
Sure.
And you combine these two synergistically, and it's awful. My dad's aunt lost half of her tongue and then part of her jaw to oral cancer before she died. And it's just...
and she was a smoker?
And it's totally disfiguring, and not to belittle other cancers, but this is one that's very obvious and has to, you're very impaired afterwards in your ability to function, to talk, to chew, and things like that. And so it's good to see this, and it's good to see less and less people smoking. By my oldest daughter's 21, and by her age, I'd been smoking for 3 years because that's what cool kids did, in college back then. And then I smoked into dental school until we opened up our cadavers, and our cadaver died of emphysema. I went to school with my cousin David, whose cadaver died of pancreatic cancer. And so I went and saw his cadaver. I'm like, what are those? He's like, those are the lungs. I was like, really? He goes, you don't know what lungs look like? I said, come look at our cadaver. So his cadaver, the lungs look like a gorgeous, pristine chicken breast with the skin off. And then ours, if you went and looked at our cadaver, it looked like a chicken breast that had been just sitting on the barbecue with the heat on for about 4 weeks. It was black and shriveled and just looked awful. And that was when I quit. And I know, I know I could stamp out smoking in teens and in kids even younger in America if I could just be able to wheel a cadaver into every 6th grade class in America, have the kids all put on gloves and have them all stand up, and whoever's the bully in the class, make him pull the sheet back and then reach in so he'll pass out and everybody can have a good laugh at that. But when you see that, you go, oh my God, because otherwise smoking, if it caused your hair to fall out, as I just randomly picked that, but if it caused purple splotches on your forehead, if it caused any kind of damage that you could see, I think people would stop. But it's invisible until the autopsy for the most part. Or
years later when, for women and men too, but particularly women, where they get all the wrinkles around their mouth from smoking, and that doesn't show up when you're 17 right off the bat. And so it takes, maybe decades before you can see the effects of it. So, I remember a while ago they were talking about potentially putting the kind of graphic images you were talking about on cigarette boxes, but that never went through.
That's not enough. You have to see it in person and really kind of viscerally experience it. Really, the only safe way is to smoke Lucky Strikes, because I saw an ad where a doctor said that it doesn't hurt your throat. That's the one brand. The rest of these brands, awful, kill you.
Yeah, sure.
Anything else?
Yes. A Georgia dentist is under fire for using a restraining device on a 5-year-old child who was having her tooth pulled. The office uses the papoose board, which restrains a child's arms and legs if excessive movement interferes with treatment or risks injury. The practice is defending its use of the board, saying every parent signs a consent form and is allowed to stay with the child during the procedure. The father of the girl said he heard her screaming, then saw she was in the device. He says he does not remember signing a consent form. A spokeswoman for the ADA said the board is designed to keep children safe during their visit to the dentist. But the American Academy of Pediatric Dentistry warns dentists of using restraints because it can cause physical or psychological harm.
Yeah, and when I saw that part of the article, the actual American Academy of Pediatric Dentistry statement says produce serious consequences, physical, psychological harm, loss of dignity, and violation of a patient's rights. And it was funny because I was up at CR with Gordon Christensen probably 2 months ago during the manufacturer visits, when the manufacturers come and bring their new products that we're going to send out to the CR evaluators to test and figure out which ones need to go to the science team. And 2 guys showed up with a new papoose board. And I was kind of amazed. I was like, oh, I didn't really realize that we were still making these / using these / hey, we've got a new one.
Right.
And it's not one with Oculus Rift glasses built into it or anything cool like that. It just had some different things about it to make it easier for the dental team to use. But I can tell you that the loss of dignity part might, as somebody who was tied to the bed by his mother because he would sleepwalk, and the psychological damage it had caused me and the tens of thousands of dollars of therapy, that is all absolutely true. I can't even remember it. I had to have my aunt tell me that I used to get tied to the bed. I mean, it's serious. The power of the human brain to repress things you don't want to remember is unbelievable. But if you're a parent, if you're anyone besides my mom, a parent watching your child being restrained like this, it freaks you out. Have you seen what it looks like when a kid's in something like this?
I saw a picture. They had a picture on the story, but that was the first time that I'd ever seen it, and it reminded me of a straitjacket. It was terrifying.
It is in a sense. I mean, it's used kind of for I guess the same sort of reason, but a different reason. They do use them in emergency rooms. I have a friend who runs an ER, and they do have to use them sometimes to be able to suture kids without them reaching up and kind of grabbing and so. But there might I don't know. I don't know if there's any difference between the papoose board or somebody holding their arms down, or maybe mom needs to hold the arms down so the kids can't live that way. They can just be mad at mom and not the office. But I can see how this is a slippery slope, and if you're going to use it with sedation, and and the kid's not going to remember it because they're sedated, and you're just trying to make sure they don't flop while they're sleeping. That's a different story. But I could see how hearing a child cry and realizing it's yours, and then going back and seeing that looks like some kind of Hannibal Lecter stuff. It's kind of scary.
Definitely. I would hope that he would have had the consent form to sign and whatever, but he says that he doesn't remember ever signing it, so it might have been a piece of paper that he didn't read like we all do, like, oh, okay, yeah, sure, here's my signature. But I don't know the full details of the story, but it would be, for me at least, if I didn't know or consent to it and then I came back and Eden, my daughter, is restrained in that, it would definitely freak me out.
Yeah, and when you do go to the doctor in today's climate, it could have been slid right in there between the other useless paperwork like the HIPAA Rights Act and the privacy, blah, 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 and all these things you're signing just because they're government regulations. But when my dad and when I, were in private practice, it was no big deal. So, but I can understand how it would be absolutely terrifying for them. I can see both points on this one. Okay, well, that about wraps it up for this edition of Chairside Live, except for Dr. Erin Elliott, who's been featured on Chairside Live interviews, been featured in Chairside Live magazine, outraged an entire specialty with her flamboyant comments, is going to be here on August 14th to take a tour that I'm personally going to do for Dr. Elliott, who lives in Idaho, home of famous potatoes. And we've issued a food challenge to other dentists. And Erin, I'm telling you right now, if you think about showing up without a food product from Idaho, And it better not be potato chips.
No.
Little too easy. Go deeper than that if you would.
Regional specialty.
That will be your ticket to the world's greatest dental laboratory tour.
Yep.
All right?
I like it.
Challenge thrown down.
Woo!
That about wraps it up now for this edition of Chairside Live. On behalf of myself, Megan, the 9 pounds of meat behind us, the whole CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. New study reveals why you should practice what
Why
you're
Hugh
saying.
Laurie really has a British accent.
Oh gosh, I'm just trying to give you bloopers, that's all. It's working.
Why?
And then in the news, a study reveals that the... Sorry, I thought James was laughing, and he totally wasn't. Researchers reported that smoking rates dropped more than 5% from 2000 to... Well, I can't say 2002 to 2012. And he's making little... Every time he's making little head movements, like, oh, she got through that one. And they came out with the Lucky Charms Just Marshmallows. Hashtag dream come true. That's awesome.
It's what I would call not so sneaky meaties.
Right.